We continue our focus on health disparities. We have Dr. Keisha Bentley-Edwards, who is a professor on Duke's Medical Center and General Internal Medicine. And we have Dr. Paul Robbins, who is an assistant professor at Purdue University. So we're extraordinarily proud to have them. Their full bios can be found on our website and a short synopsis in our programs. So we're going to go ahead and hear now from Dr. Bentley-Edwards and Dr. Paul Robbins.
Well, hello. I feel like this was our session is a good follow-up to having our nurses here and talking about what was happening on the ground. And a big part of what we're going to be talking about are the pre-existing conditions. And when we talk about pre-existing conditions, we're talking about both health as well as systemic racism. And obviously, this is chapter 1 of the Pandemic Divide book. So I'm going to give the introduction. Dr. Robbins will talk more about the meat of the book, and then I will go back with the conclusion. So before I get started, just to talk about writing, the challenges of writing this chapter when we were writing it. So our editors already brought up about how they conceived of this idea early on in the pandemic. And I was going back as preparing for this presentation, looking at the earlier drafts and our earlier outlines. And we had this challenge of understanding the virus while the knowledge was evolving. So wear masks, don't wear masks. Do we need to wipe down groceries? Like there was all this information, some good, some bad, and really trying to fine tune it so that this could be usable information. Another challenge, data has not been uniformly collected across states. So there was a period where you only had 2 or 3, I think it was 5 states that were collecting data on race. And then even now that you have less requirements, you're seeing another attrition of the data on race if you're looking at states. And then another challenge is that this was written in the moment, right? And so we're writing about the pandemic while experiencing the consequences of the pandemic. We're at home, we're worried about our families. Some of us had family members who had gotten sick, whether it was the pandemic or just living life. And we're writing it and trying to document what's going on in America with Black people while we're Black people, So those were serious challenges to writing it. And because this was such a big thing, just narrowing the scope and then also challenging that misinformation. So with that, we had to make a few goals necessary. So we wanted to know what we know while we were writing it. So if going back to the different versions, like how many people had died at this point? We've lost another couple 100,000 since our last version. Like those types of things that we had to constantly update, thinking about the myths versus the reality. And we really wanted to explain the context and make recommendations so that we can move forward better. And while we're doing this, obviously, we have everyone is social distancing, so everyone is able and sitting. Not everyone, obviously, which we'll talk about, but there were so many people who were social distancing at home who could watch what was also going on in the world. And when we talk about what was going on in the world, obviously we have what's been known as the racial reckoning. So you had these police and extrajudicial killings. So in the medical school and in nursing and the health system, we were talking about systemic racism and what we need to do health-wise. But then on the outside world, we are realizing that if we're talking about the system, we have to also think about what's happening on the streets in the communities. And so this is all part of the conversation that we're having in the health system. How do we gained interest where folks were looking before as the racism that we were seeing as a shame, but it wasn't necessarily being seen as something that was urgent. And so now, besides for the pandemic, we had an added urgency and need to really pull things together. And so this is the context that we were writing in, and now we'll actually go in, and Dr. Robbins will talk about, what were some of the things that we found.
So as Dr. Bentley-Edwards was saying, we had to think a lot about what to include in the chapter and what not to include because it was going to be limited. We knew that a lot of people in some of the other chapters were going to go into more depth. This presentation is actually very similar in that regard. There were so many things that I wanted to include and that I thought would have been amazing to include, and I refrained from doing so that you all wouldn't be here for, ever, especially right before lunch. I try not to be that person, and so keep that in mind as I talk here about some of these things. So, which one is the?
This is the right one.
Where does it go?
I think it's there. There you go.
That way?
Yeah.
So, I guess you haven't read the chapter because the book's not out yet, but when the book comes out and you read the chapter, you'll realize that we start off by talking about some of the initial narratives surrounding COVID-19. One was, and this was at the public health level and in lots of families and wherever else, people just didn't really know what to make of it. And so one of the things that they said coming into it was that all Americans are facing a similar public health threat. There's an invisible enemy. If we all work together, we can fight this thing that will strike indiscriminately. And so that was one of the initial narratives around COVID-19. Another one, which, black people are immune to COVID-19 is the thing that people were saying, and some of that was based on some of the very early data that showed that it wasn't really in Africa. And so anytime, black people do or don't have anything going on, immediately, people start going into the genetic stuff and all kinds of other things. And so these were some of the initial narratives. And I just wanted to get those out there so that we can have a quick chat about systemic racism. According to Jones, back in 1972, there were 3 primary manifestations of racism. You had institutional racism, cultural racism, and individual racism. These are they are 3 different things that sometimes overlap, and you can see some examples here that we wrote with regards to the COVID pandemic. An example of something that would be institutional racism is that the government provided initial access to vaccines based on age and occupation. Some of you might think like, oh, well, that's totally normal, that totally makes sense. However, we were seeing that there were age differences basically black people were dying at younger ages, and so setting the age too high meant that there were black people who could have been getting the vaccine earlier and were left at risk. And then the other thing with occupation, it wasn't just healthcare workers in general or anyone who works in hospital settings. It was specific people, and then they threw police in there, and they threw in the other first responders. And so they're doing all of these things and choosing all these occupations, and race and occupation very closely related, and so that kind of put people at a disadvantage. Even though it wasn't intentional, it can still happen, and it happened at the institutional level. Sorry, even though it may not have been intentional, I don't want to speculate on people's hearts. Cultural racism, if you think about ethnocentrism and the way that works, sometimes you're not really thinking about how things might affect other groups, and so you might think about, oh, well, if we just check people's oxygen levels, we can decide who does or doesn't need assistance. And when you start thinking about some of the data that came out later about how some of the pulse oximeters actually weren't reading people with darker skins oxygen levels properly, that means we were delaying treatment on people, we're not checking people into hospitals, or that sort of thing, and that can be a problem. And so that's the sort of thing that without ethnocentrism, maybe people are thinking about how to address that problem and do it some other way. And then individual racism, I'm not saying that this was widespread necessarily, but if you're talking about black people in general, one of the ways might be that someone sees a black patient and they say, oh, black people don't like needles. I'm not going to bother trying to convince them to do this vaccine, or they seem resistant in general. I don't want to talk them into it. And so you are leading with racial bias rather than protecting people's health. So that's the thing to factor in there. Just wanted to include this quote. Institutionalized racism manifests itself both in material conditions and in access to power. And so you're going to hear some about material conditions, less so about access to power, but I want you to look at the date on this. It was from 2000, and so this was 22 years ago, and there was actually a bunch of research being done even before that on some of the institutionalized and structural racism, and we still have a long way to go on that. We're still not moving fast enough on looking at some of those things and figuring out ways to alleviate the institutionalized racism. Yes, sorry.
For that, no, you're fine. You don't have to go back.
Okay, cool.
The thing to emphasize is that racism not only harms groups of people, but there's a specific benefit to other groups of people. So that's the thing to emphasize here, is that as we talk about these health disparities, we also have to talk about health benefits and access to better care and resources. So just as a reminder that it's not just that some people are being harmed, but some other folks are being benefited.
Now that I've reminded you all that systemic racism exists, let's revisit the COVID narratives. So again, all Americans facing similar public health threat, and black people are immune to COVID-19. Spoiler alert, those of you who lived in the world and hung around for just a few months for people to start disaggregating data, what you saw are things like this. This is it's 2020 from June 9th through December 8th. And you can actually track the differences in the mortality rate. And you can see that if we were all in it together, it seems that some people who are in it equally to other people seem to be dying at disproportionate rates. What I'm saying is that it doesn't appear that we all were facing the same threat. What I would like to point out, and if you don't really pay attention to anything else, when you read the chapter and when you hear us speak about this, this is a main takeaway. Due to long-standing disparities, COVID-19 represented a unique threat to the health of black Americans, and I think that you should consider that when thinking about the rest of this. So some of the things to consider: pre-existing health conditions, and these are some of them, and we'll talk more about the longer list and that sort of, but these are things that we found later were related to COVID, and also thinking about healthcare status, whether people are insured, and whether they have unpaid sick days and they can take days off and that sort of thing. And then also just the lived experiences, thinking about what it's like at work, thinking about what it's like at home and in neighborhoods. And we'll talk more about some of the things for there as well. But these were kind of the three main things that we focused on. And while these are on separate, lines, I guess, there's some overlap and intersection and that sort of thing going on. So I don't want anyone to think that that's not the case, but I just had to put it up here and make it easy for you all to read. Talking about pre-existing health conditions first. So according to the CDC, you are more likely to experience severe COVID-19 symptoms if you have the following risk factors. So things like asthma, chronic kidney disease, diabetes, heart conditions, obesity, and there was actually a very long list that I didn't include here. Some of the diseases that I included here, I have graphs for, others I don't, but again, there was too much to include, so these are some of the things that were listed. It should be noted that Black Americans experience higher prevalence of many of the health conditions, and so basically when that have been linked to severe negative outcomes. So basically when the pandemic started, we were already at the disadvantage that our society had created, and so we were already set up to not have similar outcomes as everyone else. Here's an example. So between 2017 and 2018, if you look at the age-adjusted prevalence of severe obesity, and so I chose to show you severe obesity because, you know, obesity is kind of a weird measure. It just is. And I wanted it to be clear that I'm not talking about someone who's just like a little bit overweight or anything like that. I'm talking about severe obesity and its relationship. And what you can see from this, and this is from the CDC's website, is that non-Hispanic Blacks have higher rates of severe obesity. So again, this was like right before the pandemic started. You also have similar findings with diabetes, so you can compare non-Hispanic Blacks and Hispanic people to white non-Hispanic people and see that there's quite a gap there. And those error bars are for the 95% confidence intervals, if you're wondering. But what you can see here, higher prevalence of diabetes, which again, related to negative COVID outcomes. Yeah, baby knows what's up. Anyway, it makes you want to cry sometimes. It's, you know. Anyway, so the last one I wanted to show is asthma. So Black Americans and Puerto Rican Americans both have higher prevalence of asthma, and it should be noted that they're more likely to have severe, especially Black Americans and Black women in particular, severe asthma outcomes where you die from having asthma. And so if you have a respiratory illness and you already have this built in, you know, again, we're going to expect to see negative consequences from contracting COVID. You keep looking like you had to say something.
I was going to say something.
Go ahead,
You know
man.
me well.
Throw it in there.
And this gets back to what our nurses were saying, uncontrolled chronic conditions, that's part of it. And this uncontrolled aspect is not just about personal control, but also if you're going to the emergency room for asthma specifically, and there's no follow-up, they're like, oh, go see your primary care provider, and you may not have a specific primary care provider, or you're at a clinic where it's rotating. You don't have that continuity of care that makes it easier for you to have your chronic conditions controlled, whether it's asthma, diabetes, hypertension, or obesity.
And one thing that I don't really note in the slides, but I think we should all be thinking about as well, is that people see these sorts of disparities and often think like this is just normal and that these sorts of things should happen. And in reality, this stuff is preventable. And I don't mean it's preventable at the individual level. I mean, there are system level changes that we can make, and we will talk some about that toward the end of this. But these higher rates, again, are more related to the conditions that people live in and the things that they have access to help them maintain their health, and the things that they lack access to as well with those regards. So. Also from the, this is the same slide. It was supposed to be funny because what I was going to do is point out that they mentioned race and ethnicity as one of the medical conditions that you might have. And it was funny to see it on there. So you see the other list, and then you see race, ethnicity, and I just want to note, because I want it to be clear to everyone.
We're not afflicted with blackness.
Being black is not a risk factor, and this lady thinks that it's funny that the CDC or anyone else might suggest a thing. And to be clear, the CDC actually went in, and if you read, which some people don't, and that's why you have to be careful about just putting stuff like that in big headlines. The CDC did clear up that they believe that there were systemic things going on, but it was a really small paragraph. Anyway, the biggest issue is that while people think that race is a factor, it's actually racism, and it's the racist systems that, again, black people are living in and that we have to endure every day, that contributed to some of the disparities that we were seeing. We can also look at living conditions. And there's actually too much to talk about with this, but I just wanted to mention a few things. One is that black people are more likely to live in multi-generational homes. And so what that means is that you have really young people potentially living with grandparents and great-grandparents who might be getting cared for, or, people might like supporting each other in these family contexts. And while that's typically an advantage and a great thing that might be happening, sometimes it's by choice, sometimes it isn't, but these multi-generational homes means that when a 20-year-old goes to their job and potentially that job puts them at risk for contracting COVID, and then they bring that home to someone older who might be staying at home, you're looking at higher risks of being exposed, even if you're not going out anywhere and you're just living where you normally live. Other things to consider, there's a plant here and it's kind of blocking, so I'm trying to, a lack of access, I think it says, to
Health and wellness.
Lack of health and wellness spaces. Okay. So what I mean here is some of these same spaces were things that could have contributed to some of the rates and prevalence of health that we were seeing earlier. But even beyond that, like living in spaces where people don't have the ability to get outside and exercise, and or don't have the ability to do what others are doing as they're trying to maintain their mental and physical health during the pandemic, helps to create people who are, again, more at risk for some of these same conditions, or contracting COVID and experiencing worse outcomes. Should also look at the environmental hazards that exist, and a couple of things to point out about this. One, and again, I'm not going to speculate on intentionality, but black neighborhoods tend to have a lot more pollution being dumped into them by transportation and things like that, but also just by businesses that are allowed to pollute in some of these spaces. And the same is true of low-income people, and being low-income and black, obviously an issue as well. And the other thing I wanted to point out is that environmental issues aren't everything, and they can't be, because you have in some places that are very densely packed, like New York, where you see black people who live down the road from, or a block or two over from white people, that the white people who lived the block or two over still had better health outcomes, and still had less exposure to some of these things than black people who literally live, a block away. And so those are things to consider as well. And then what a lack of wealth can mean for what it is that you have to do or can't do with regards to your job, or with regards to taking space away from things, or being able to live near places where you have access to a decent hospital where you can get great care. And those are the sorts of things that wealth can help you get to, and that the lack of wealth kind of puts black people at a disadvantage there. And I kind of wanted to point this out, and again with the plant here kind of trying to block me a little bit, there are differences in people's experiences with the pandemic. And you can see on here that when the Kaiser Family Foundation asked people to say like how much you have been affected. So for the first one, it's the people who said that the pandemic has had a negative impact on the ability to pay for basic necessities. This is where a lack of wealth comes in. If you're out of a job and there's no wealth to back you up, as things are shutting down, you might have a harder time paying for things. And then also, if you
Fallen behind.
Are you able to read those?
Yeah.
I'm really
So also you have a larger percentage of Black and Hispanic people who felt that they had fallen behind in paying their household expenses. and particularly about worrying about becoming seriously sick from coronavirus. 41% for Black participants or respondents, and 57% for Hispanic respondents. And then this last one, having a close friend or family member who had died of COVID. And this will also help you understand even the country's response to mitigating efforts. When you talk about what is your lived experience, whether or not being in COVID, in the heart of the pandemic, particularly in 2020, whether it was a convenience, an academic exercise, or if it was a real trauma, right? And that's where you have these distinctions that you can see by race, about the ways in which people have responded and continue to respond to COVID.
Yep, thank you. I also kind of have hinted at this a few times, but I just want to get into talking a little bit more about working conditions. So Black people are more likely to have jobs where they're considered to be essential workers, and especially the types of jobs where you're an essential worker that isn't necessarily the protected class of essential workers. And you know, if you think about how poorly we treated some of our healthcare people, imagine how much worse it is for people who serve food or deliver food or, you know, drive buses or, you know, just all of the different things.
Pick the crops.
You know, yeah, all of that. And for some, you know, there's a higher prevalence in some of the risky jobs that we might see. And so one of the places to think about is like meat packing plants and these sorts of things where you might see more Black people working at these places. There are a lot of Hispanic people there as well, so I want to be clear about that. But you might see more Black people working at these places, and there was a concerted effort to make sure that these meat processing plants were not shutting down during the pandemic and were staying open at all costs, even as these people are dying there, working on top of each other, piled in really tightly on this assembly line, trying to make sure that you know, our food is able to come out. And so these risky jobs were part of the working conditions that Black people were in. Also the financial insecurity, and I talked some about this earlier, but I want to reiterate that for some people, you know, if you're not on a salary and you're working an hourly job, maybe you can't just take off work to see whether your symptoms are COVID and you just have to go with it. Maybe you can't go and afford the test or get the test because you don't want to know what the answer is, because you have to go in and make sure that your family is going to be taken care of financially. You don't want to risk losing your job if you can't come in for several days because you do experience severe illness, and then they replace you with someone else who lost their job at another place. And so these are the sorts of things to be thinking about. And as we were writing the chapter on this, I was thinking about people who I'm related to who lost their jobs and found themselves in this sort of situation. And we, you know, as a family had to put together resources and try to help each other out. But financial insecurity can make people do a lot of things that they wouldn't normally do, including go into to work and potentially infect and or kill your coworkers. So the last thing
is the lack of health benefits.
Lack of health benefits, which is kind of related to that, but Black people are more likely to have jobs where they don't have these sorts of health benefits. And this goes back to what the nurses were talking about earlier as well, where if healthcare is a human right, and we're not like, oh, well, if you do this job, you can be taken care of, you do that one, maybe not so much. Maybe we're not in the same position as we found ourselves in. So just so you know, I'm not just saying that some jobs are riskier than others. This is actually a study that looked at in California for residents between 18 and 65 years old by occupation, what the mortality risk ratio looked like for different jobs. And you can see that if you are a non-essential worker, there was definitely risk. However, for those who were working in food and agricultural sectors, the risk was a lot greater. This random blue box here isn't to make it look pretty. It's actually to hide that when they disaggregated the data by race, you can see that there were actually two groups who were very severely impacted in comparison to the other groups, and that would be Black and Latino workers in these sectors who all faced higher risk of COVID mortality. And so just wanted to point out this study, and this is a case study for why disaggregating data is important, and collecting data that allows us to see who is or isn't being impacted and who's the most vulnerable is important, because it's impossible to make policies that address these sorts of things if you don't know who's more at risk, and if you don't start understanding what sorts of things are contributing to that risk.
And for this chart, it also shows how we talked about earlier, how systemic racism harms specific groups, and it provides benefits or protections to other groups. So you can see for Black and Latino in every group, for Asians who are in the health and emergency field, you see this increased risk that is not the same for white people in the similar jobs. And you actually find for some of these groups, they actually had a lower risk of mortality from March to October. So there was actually a benefit to not being around other people that was found for white people that was not found for any of the other racial groups. So systemic racism harming Black, Latino, Asian folks, and having very specific health and life or death benefits to white people. So essential workers also becoming disposable workers, and we wonder why there are so many job vacancies.
I would also, related to all of this, I don't know why I'm following you up after you just dropped the mic like that, but thinking about the government and community, the types of jobs that you might have if you work in that sector, if you're white, are just very different from the types of jobs you might have if you're from some of these other groups. And so it should be noted that even though they're working in the same sector, you know, if you're a government official who's a government official, that's different from someone who works for the government and, you know, is the janitor or, you know, prepares food.
A government job.
You know, a government job.
A government job versus being a government official.
Yes.
Precisely.
I also want to point out that a lot of the stuff that I just presented was from earlier in the pandemic. And the reason that I kind of wanted to make this point is that we have been able to, through the work of a lot of different types of people in a lot of different areas and sectors, have been able to start improving on COVID outcomes. And what you see is, you know, while this racial reckoning and all of these things are taking place, you see people saying, all right, we need to do something about this. Let's start putting things in place. Some of it happened at the government level where they were giving out money and helping people, you know, have more financial security, or, you know, giving people better access to different healthcare stuff and, you know, that sort of thing. But you also see people who were trying to work against all of this stuff and who were politicizing not only mask wearing, but vaccines and all kinds of other lockdown measures. And I think you can, when you see the next slide, I think you will see what I mean by countering resistance. And so if you look at and this is from the CDC, if you look at the age-adjusted death rates in 2020 versus 2021, the 2021 ones aren't up yet, but for Black Americans, 142 out of, you know, per 100,000. For white Americans, 66.6 per 100,000. But what you see is in 2021, the rates actually went down for Blacks, whereas for white Americans, the rates are actually going up. And again, this is potentially the impact of politicizing health in a way that, you know, is leading to more white people dying than were dying when the pandemic first started, when we knew absolutely nothing about it. I should also point out, while we're sitting here, that these numbers are still very disparate, and so people are going to make it a narrative that white people are dying at whatever rate, and even in increasing in the ways that they have, they still aren't touching the rates that Black Americans are dying at. And so there's quite a gap here. And I don't want to overlook that, but I want it to be noted that while we're resisting and trying to keep the numbers of Black people who are dying down, some people are apparently working to make sure that white people have the ability to die faster. I don't know.
Not the plan.
Hopefully not the plan.
Yeah.
It's a horrible idea. I just wanted to point it out.
That's not the way to reduce disparities.
No, it is not. We do not advocate for that. So this is directly from the book chapter, and it's a quote. Keisha and I were trying to decide which of us wrote it. The more I read it, I was like, I think it was me, but that's only because I like it. People were trying to stop us from thinking about system level things that could be done, or thinking about systemically what sorts of things are happening. And you've seen that resistance in a lot of different areas. But I wanted to point out that recognizing systemic failures does not eliminate personal agency around health behaviors. So I'm not saying that there aren't people who are doing things that might be contributing to their health differences or whatever. I'm not saying that. But looking at the systemic failures does recognize that health behaviors, conditions, and outcomes are informed by the societal structures that people live in. It's thinking about how important context is, how important, how context matters for shaping everything. And this is one of the reasons you should read this chapter. I think it's amazing. It's an amazing book and an amazing chapter. And there are all kinds of other chapters that say amazing things. I'm just saying. I want to say amazing one more time. Turn it back over to Keisha.
So the takeaway, and if you are talking about radical reforms, bringing up Martin Luther King never hurts. And to be clear that human progress never rolls in on wheels of inevitability. So basically a passive approach that things will get better. It has not worked so far. There were people who said as more Black people get educated, these disparities would be eliminated, but we find that the disparities are actually greater when we compare apples to apples, highly educated Black people to highly educated white people in a number of things, whether it's infant and maternal health, prostate cancer, breast cancer. So we already know that doing nothing will not help. So let's do what needs to be done now. Have a sense of urgency. And so thinking about what we need to think about when it comes to research policy and practice, taking action, being intentional, respecting Black patient advocacy. So Dr. Trotter talked about this history of Black people coming in to save ourselves because we can't wait for other folks to come into our aid. And that was also true during the pandemic, particularly when we talk about churches and community organizations leading the way when it came to testing, COVID testing, as well as vaccine rollouts, making sure that people had food. There already was a mutual aid system, but now there were better partnerships with academic institutions. Disaggregating the data, we saw that when we looked at the data when it came to age-adjusted work, as well as looking at vocations. And be specific and be honest. What is it that you're actually looking at? If you know what the data says, why are you making remediations based off of generalized data? If you know that you're trying to eliminate health disparities, why around race, why are you only talking about poverty? Looking at institutions and systems versus individual behaviors. Individual behaviors are like the low sexy fruit, but that will help you and is great to help an individual, but you can't move the needle. Obviously, we need to eliminate systemic racism and reevaluate your contact experts, and we'll talk about that in a second. But there are other areas that we need to learn more information about. So early on, I said we tried to write this chapter on what we know now. What is the data? We had a lot of things we could speculate about, but the data wasn't there yet. So looking at the way that the hospitals were shut down, where for a short period you couldn't have anyone in the hospital with you. And then in the maternity ward, you may have been able to bring one person in. It limited the amount of advocacy that pregnant people could have. And now the data is coming out that the things that we suspected to happen, that maternal death was going to increase, it did overall, but especially for Black people. And so we know more now, but we need to actually find, and now that we know the problem, we need to go deeper into it. So we know that roughly 25% of overall maternal deaths since the pandemic are related to COVID, which is huge. We know that there was a huge increase for Black women who were already disproportionately more likely to die in pregnancy. And then we need to learn about the long-term effects of COVID, right? So a mild case, a chronic case, what does it do to your body? And then also we need to know more about long COVID, which a lot of people denied, and now it's here with us. We need to talk about that. We need to also talk more concretely about COVID and ableism, as well as looking at immunocompromised people and how, in a lot of ways, we have sacrificed the health and safety of immunocompromised people to get back to what some people would like to think of as normal. And so going back to reevaluating content experts, especially as we talk about researchers, to not just look at me. You know, obviously, I would consider myself a content expert on racism, but we should also be talking to families and patients as collaborators, not just let's do a town hall, but actually a collaborator on your research, partnering with community leaders that you actually tapped into when it came time for all these rollout initiatives to build trust and trustworthy systems. Obviously, researchers, and when I put up researchers, I'm talking about people who've been doing the work for a very long time to make sure that you're not engaging in health equity tourism, meaning that you're only coming in because it's funded right now. This is real work that folks have been doing. Who are you citing? Who are your co-investigators? For practitioners, if you want to be excellent at your job, you need to be excellent with everyone. And for government and policymakers, those also, it's not enough just to know that systemic racism exists. We also have to engage with policymakers so that the policies, both at the health system level and the community and larger, can change so that we can do better. And to remind you, when we talk about being specific, if you want to fight racial disparities in health, you must actually focus on race and racism. It seems really straightforward, but for political expediency, it's often a focus on poverty. But when we look at the numbers, you actually have to look at race and racism broadly because it impacts people differently based off of their social class and education. And I think that's it. We're ready for questions. There's someone in the front.
Thank you once more for the wonderful presentation. I can't wait to read and devour the chapter when the book gets here. So anyway, if you go back to your slide on living conditions, I think I really love how you presented the information. So the city of Albuquerque did a similar a study, but we focused, or our approach was on using what we call the Social Vulnerability Index, where we combined or use the tool to look at things like the socioeconomic status of a family, household composition, minority status and language, and of course, English language proficiency. And we were using also GIS to do mapping based on the zip codes of areas where COVID was predominantly occurring. And our findings also indicated, like you present here, that the social vulnerability index tended to be higher in areas where we had minority communities living. And then the other element that we experience in New Mexico is we also experience another segment of the population, the undocumented communities and refugees that were not readily catered for or factored into the healthcare provision and access. So I think I really like what you guys are presenting here. Mine was just a comment to your chapter, and I think we should make it more wide scale and spread so people can be able to learn from that. Thank you.
Absolutely, thank you.
Great point.
Hi, can everyone hear me? Dr. Robbins, you talked about differences in blood oxygenation levels as an example of, I believe it was cultural racism in the specific context that the measurement for blood oxygenation, pulse oximetry, yields inaccurate results for African Americans. And on the one hand, while you could say clearly that it's racist that the test was designed solely using data over the years of white individuals of European descent, I'm wondering if you could comment about what's interesting and controversial about this. Because acknowledging the problem seems to require acknowledging innate physiological differences. I'm wondering if you have any comment.
Can you repeat that last
Yeah,
part?
he's
Because I'm
talking-
not really sure I'm not sure what that means.
Yeah, so basically this is purely about darker skin versus lighter skin. So, and the reason we were very specific about the way we wrote it as well as the way the authors wrote it, because of the way that the pulse oximeters, if you've been, whether you can pick one up at CVS or you've been at the doctor's office, they put it on your finger, and it reads through your skin to measure your blood oxygen level, the saturation. And so this one isn't specifically about race just because we know you can be light or dark and still be black. But it's the darker skin, what they found is the error rate was higher if you had more pigment, because it was normalized. And that's why we put it in the cultural racism aspect, because the testing to decide what was the accuracy. Now, I do want to be clear, for both groups, it was the margin of error was larger, was 3 times larger for black people in large data sets than it was for white people. So there were some white people who got error messages where when they did follow-up tests, that they realized that people who were being cited as having normal blood oxygen levels, in fact, actually had clinically low blood oxygen levels. So, but it was 3 times higher of that error for people with darker pigment. So I'm glad that you brought that up to clarify.
Yeah, no, that makes sense, yes. Thank
I
you.
also want to say that when you're talking about things like cultural racism and that sort of thing, like the ethnocentrism is important because, colorblindness and the colorblind approach to things in general is what keeps yielding some of the same status quo things that we're seeing, some of the gaps that we're seeing. And it may feel to some like it's a more passive thing, like, oh, they're not doing it because of race, they just are designing this thing. But if we start by asking questions that work from the assumption that throughout history, different things have created gaps, and you say, we want to make sure that nothing is getting in the way of this, and that's one of the things that you test out. So I'm not suggesting that people that make these things are like, in the Klan or anything, but I am saying that if you're out here operating from a colorblind perspective, we can't tell the difference sometimes between you and the people who are intentionally being racist.
Yeah, and that is exactly the point right there, is that when this study came out, there were a lot of folks who said, well, this wasn't a racist incident. This was just an error in the system. But the data is only as good as the data you put in, right? Garbage in, garbage out is what you learn. But the cultural racism is the fact that it didn't occur to people that maybe we need to test this on people of varying skin tones. So Dr. Chani, thank you for bringing that up.
Yes, first of all, thank you. Great presentation. Just one quick question. This is just sort of trying to understand you all better. What is one thing that you have learned about yourself as you have prepared this great work?
Whew, I'm tired. That's what I learned. What I've learned about myself is that I am more patient and impatient at the same time. So, when we talked about realizing that for some people, this was an academic exercise when we talked about the pandemic and people dying, or that this was an interesting research question. When I have family members that are sick, my children are home with me while I'm trying to do this, and have young family members that are in the hospital or dying or have died. And the nurses here, my heart is with you. My brother is an ED nurse in Los Angeles, so I'm scared about him, make sure he can come back home to our family. And I became increasingly impatient with having to explain to people who should know better that racism exists. But I also had to pull from my own patience to say, you know what? Big picture versus little picture. I could be angry with you and move on, or I could find it in myself to make sure that we can keep more people safe and healthy. And I will explain this. I will explain racism another 1,000 times today if it means that it will save more people. But I will still be a little mad about it. So.
Hi. Oh,
Sorry, I was going to quickly say something I learned about myself was just how much of an influence my family has on my thinking, like just thinking about the experiences of, I have a pretty large family who have varying types of jobs, and just looking at the differences, it was just, it's part of what inspired some of the things that that I started looking more into and writing about. And so shout out to my family.
Yes, the questions that we ask, right?
Hi, Javay Grooms from Howard University. Thank you for your wonderful presentation. I wanted to know, what is your hope, right? If you from this work and in the future, whether short-term or long-term, what is some policy implication? What are some actions that you hope it helps stimulate or motivate?
Did you want me to go?
I always just hope we can figure out ways to ask better questions and help people live as long as everyone. Like I don't want to see disparities, and I want us to close the gaps completely in instances where that's possible. And the problem is that it's possible in so many places, and we're not really trying to address it. And so my hope is that we get better able to do that. That if we make a big enough noise, if we make a big enough deal about some of these differences and how something can be done about it, that maybe people will start collecting better data, we'll start asking better questions, and we won't have to keep seeing the things that we're seeing. Keisha?
My hope is that we actually address institutional racism, right? So individual cultural racism is supported by the institutions, so you can't have, individual racism can't flourish unless the system supports it and doesn't offer accountability. And so my hope is the accountability. And as one of my mentors said, this train is running towards equity. And if you have questions, you can get off on the next stop. But we are moving towards equity, and that is really what my hope is. So I hope all of us are on the train. Y'all seem like pleasant people. Mm-hmm. Okay.
It's not really a question. I think it's more of a statement. Mm-hmm. So I'm Judith Street from literally just down the road. I'm not connected to Duke. I'm just here because
thank you for being here.
My interest in the issues of race really stemmed from the fact that I wasn't born here, and I've only been living here for the last 10 years. And for those people like myself who didn't grow up in the United States of America, although I came from the vestiges of, or the ramifications of colonialism, I need for you to understand, for those of you who are born here, how it impacts people like myself. Because even when you raise the issues, when you're speaking about the data, talking about how people look at that the pandemic the COVID was not directly related to black people, or that black people were immune to it, whatever it is. For somebody like me, it strikes at a deeper level because I didn't grow up in here and I'm very unaccustomed to it. And so I think it's important for those that are on the outside coming in to say, hey, this seems to be something that is so unjust. And in my view, and I brought it up earlier, I really think at the end of the day, it's going to end up being a matter of economics.
Absolutely.
And even as it relates to the perception by the white population about how black people handle their wealth, because there's also discrimination around that.
Absolutely.
If the truth be told. Like, if we were to do reparations, could the black people handle it? And I think those are the difficult conversations, because when you start to touch wealth and power, then you're dealing with a different beast.
Well, another aspect of white supremacy starts raising up, because there's this assumption that black people are going to spend it on tennis shoes and liquor and drugs, right? And we know that's not true. Professor Darity, he's done the research to see the way black people and white people spend their money, and it's particularly disposable income. And we know that that's not true. But that's where those narratives come into play. So that's a big part of what we have to do, is control our own narratives, but then also make sure that the policies are reflective of the actual facts. And also, you know what, you asked about another policy. I would want healthcare not to be connected to work, so that you can have that continuity of care, and as well as financial incentives as well.
Can I throw one last little thing in? I'm less concerned about how black people will respond to reparations. There are other groups whose response to reparations a bit more concerning to me. That's all I'm going to say. I don't want anyone tracking me down, but I think we'll handle it fine. I think we have to ask how everyone else might handle it if it happens.
Thank you.